For locally advanced non-small cell, the real distinction is only whether a patient is an appropriate candidate for consideration of surgery. That could be, and often is, preceded by chemotherapy or chemo and radiation concurrently. That is almost always reserved for patients who have stage 3A disease and is very rarely pursued for patients with stage 3B disease based on our prior experience and the difficulty of achieving good long-term results with surgery for stage 3B. But even in the setting of stage 3A, we need to carefully delineate which patients are good candidates for surgery and which ones are better served by pursuing an approach of chemo and radiation with curative intent. So for patients with multi-station nodal disease or bulky disease, and I would say that's the majority of patients with stage 3A non-small cell, they are going to be very good candidates for chemo and radiation concurrently, and now ideally followed by consolidation durvalumab. But a subset may be candidates for surgery, but it's really something that I would say should be carved out as the minority of patients, not as an expectation for most patients with stage 3A disease. The question of what is resectable is pretty open-ended and is in the eye of the beholder. It depends on the surgeon, and the extent of disease is not really that well defined. Patients may have strong feelings in favor of or against surgery. And I think this is the setting where, more than anything else in lung cancer, we really need to rely on a multidisciplinary tumor board setting and multiple disciplines being involved in the decision. I would say that stage 3A lung cancer, non-small cell, should be generally treated as non-surgical, with the exception of less bulky, under 2 or 3 centimeter mediastinal nodes, and preferably just a single nodal station involved. And we would like to see that these patients have had a good response to the induction chemo and radiation before going on to surgery. What I think is interesting about the Pacific trial and the benefit demonstrated with consolidation durvalumab for a year after chemo radiation is that we know and have seen a huge benefit in terms of progression-free survival. We also know now that there's a significant improvement in overall survival, but we have not seen the data yet. This may tip the scale more in favor of chemo and radiation for those marginal cases on the bubble than trying to shoehorn patients in for surgery because they might possibly be that. I'm not sure that patients who are on the bubble for surgery are well served by pursuing that if they are not strong candidates, especially when our historical comparisons of chemo and radiation without surgery versus induction chemo or chemoradiation followed by surgery have demonstrated very similar results for the stage 3 population. So historically, without durvalumab, they've been comparable. With durvalumab, I would say this even tips the scale more toward a non-surgical approach. And so, yes, I would consider it, but I would really hope to define who's a good candidate for surgery based on the extent of their disease initially, more than their response to treatment and kind of making up the decision on the fly during the course of their treatment. Because we also don't want to stop the chemo and radiation partway through and then have to pick it up again. Patients who have treatment breaks tend to not do as well. It's a minority of patients will demonstrate progression of the disease after chemo and radiation, somewhere in the range of 10%. And so you can never presume that's going to be the case, but some will have nodules in the other lung or bone metastases or liver metastases, and that's one of the key things we're looking for in the weeks immediately after chemo and radiation. We'd also like to see if there's shrinkage of the cancer, and that's common, but it's also very common to have an ambiguous findings where there's some residual disease where the cancer initially was, But particularly in the weeks immediately after chemo and radiation, we can't know what is viable and what is not viable. It's not uncommon for there to be continued shrinkage in the weeks to months as we follow patients afterward, just as the chemo and radiation are leading to ongoing effects. We can't know whether that is just residual post-treatment scarring, or there is dying cancer, or still viable cancer. So it's very common for there to be ambiguous but some improvement, and not to know whether a patient is likely to be cured or not with further treatment, and a minority of patients will demonstrate progression elsewhere.